Welcome to this explainer. Today we're diving headfirst into what is honestly a fascinating yet entirely silent detective story, liver disease. We're going to track its whole journey from being a totally invisible threat all the way to a complete system breakdown.
Let's kick things off with a question that completely flips how we usually think about organ failure. What if the absolute deadliest phase of liver disease showed literally zero obvious symptoms? Right? Because when it comes to the liver, the real battle is actually fought long before a patient ever feels even slightly sick.
There's this massive gap in how we actually handle this disease in the clinic. Think of it like a giant iceberg. Up top, highly visible, you've got end-stage cirrhosis. That's the tip of the iceberg we usually see in hospitals, when things are already pretty dire. But hiding just beneath the surface is chronic hepatitis, this completely asymptomatic, massively missed opportunity. We're consistently catching patients right at the tragic end stage when we really should be finding them down in that totally silent chronic phase.
Now, what's genuinely bizarre here is that the body actually does drop early breadcrumbs, even when the disease seems silent. We're not talking about sharp pains. We're talking about stuff you'd easily brush off as just working too hard. Things like unexplained, really profound fatigue, altered sleep rhythms, maybe some muscle wasting, an uncharacteristic loss of libido, or hepatomegaly, which simply means an enlarged liver. These little, seemingly random clues pop up way before the liver structurally fails. They're your early warnings that this thing is actively progressing.
So how do we actually catch it early? Well, the answer is incredibly simple. A routine liver function test. When you see your ALT and AST enzymes elevated, specifically hovering just under 150 units per liter, and importantly, with the ALT higher than the AST, that right there is your ultimate early warning alarm. You don't need complex, super expensive scans right out of the gate. This basic biochemical signature is exactly what you should be asking your doctor about at your next physical to catch this in time.
And if we look at the major culprits driving all this damage globally, there's been a massive shift. Historically, we talked mostly about alcohol and viral hepatitis, right? But today, NASH, non-alcoholic fatty liver disease, has completely surged to become the dominant global killer. It's taking up the vast majority of cases. Take India, for example. They've transitioned rapidly from alcohol-dominant disease directly into NASH. Genetic, autoimmune, and biliary issues make up the rest of the pie, sure, but NASH is absolutely the single most important target worldwide today.
The great news is, catching the disease in that early chronic phase unlocks some highly effective medical tools. For NASH, we now have powerful options like saroglitazar, semaglutide, and pioglitazone. For hepatitis B and C, antiviral drugs like tenofovir and velpatasvir are absolute game changers. And for genetic conditions, we've got D-penicillamine for Wilson's disease or even simple phlebotomy for hemochromatosis. If we find it early, we genuinely have the tools to stop that ticking clock in its tracks.
But get this, even more surprisingly, for NASH, which again is our #1 global culprit right now, sometimes the absolute best tool isn't even a medication. Just losing 10 to 15 kilograms of body weight can trigger a brilliant, disease-reversing response. Think about that for a second. Without any complex pharmacy interventions, a targeted, moderate drop in weight is enough to pull a patient right back from the brink entirely on its own.
But if we miss that critical early window, we officially cross over into cirrhosis. And notice how the clinical definition of cirrhosis doesn't even mention symptoms? That's because cirrhosis is strictly a structural, architectural shift inside the liver. The normal healthy working units, the lobules, are physically replaced by hard nodules tied together by tough fibrous scar tissue. You can have this profound structural damage and still feel completely fine. That is exactly why early screening is so incredibly vital.
Let's break down exactly how that structural collapse happens. Using a tool called a FibroScan, we can literally map the physical decline step by step. It kicks off at stage 1 with mild scarring around the liver's main blood channels, the portal tracts. By stage 2, that scarring starts forming thick bands, or septations. Stage 3 is a major escalation. It's called bridging fibrosis, where scars physically connect those tracts together and you start seeing early hard nodules. And finally, stage 4 is full-blown structural cirrhosis. We're essentially watching a slow-motion architectural collapse of the organ.
Once you hit that stage 4 cirrhosis, the whole system turns into an absolute household plumbing nightmare. The core issue becomes portal hypertension. Essentially, the pressure inside the liver's main vein violently spikes. Why? Because of a deadly combination. You've got increased blood flow pushing in and massive internal resistance pushing back. This is the ultimate tipping point where the liver's physical changes start wreaking absolute havoc on the rest of the body.
Now, this massive internal resistance is really a two-part problem. First, you have the mechanical side of things, those hard physical nodules we just talked about. They directly compress and crush the sinusoids, which are the tiny microscopic blood vessels inside the liver. Second, you have a functional breakdown. There's this bizarre decrease in localized nitric oxide, which is the stuff that normally keeps your vessels relaxed and wide open. Without it, the vessels tightly constrict. So your pipes are basically being crushed from the outside and forcefully tightening from the inside.
Because the liver is totally backed up, the body desperately tries to decompress all that pressure, and that triggers a really vicious cycle. First, it tries building emergency bypass pipes to reroute the blood. But that kicks off a chain reaction. Blood vessels widen massively everywhere else in your abdomen. This sudden shift actually alters your gut bacteria, allowing toxins to leak straight into your bloodstream, creating a toxic state called endotoxemia. And finally, because those blood vessels are so wide open, your kidneys get tricked into thinking you're dehydrated, so they retain fluid, swelling your blood volume and flooding the system with even more pressure. It's a complete mess.
So, how on earth do we spot this plumbing disaster early? Well, before anybody orders an expensive scan, a simple bedside check gives us a really practical clue. Because of all that massive pressure backing up, the spleen gets greatly enlarged and actually starts trapping your blood cells. If you're looking at a routine blood test and see the platelet count inexplicably dropping down between 50,000 to 100,000, alarm bells should definitely be ringing. That specific drop is our very first signal that portal hypertension has officially kicked in.
Now, having high pressure or even cirrhosis doesn't necessarily mean you have decompensated cirrhosis. You don't officially cross that terrifying line until the pressure cooker actually bursts. Decompensated cirrhosis is strictly defined by one of four severe events: jaundice, which means total liver failure; ascites, a massive pulling of fluid in the abdomen; hepatic encephalopathy, where toxins bypass the liver entirely and hit the brain, causing extreme confusion; or a variceal bleed, where those emergency bypass blood vessels literally just rupture.
By this incredibly late stage, all that inner chaos becomes fully visible on the outside of the patient's body. It's driven by profound hormonal imbalances and a completely failing circulatory system. You might see palmar erythema, just bright red palms, or a really striking sign called caput medusae, where swollen veins radiate out from the belly button, almost like a spider web. Because the liver can't process sex hormones anymore, males might experience gynecomastia, abnormal breast tissue growth, and testicular atrophy. And particularly in alcohol-related disease, you'll often see localized hair loss and Dupuytren's contracture, where the fingers are physically pulled inward, curled tightly toward the palm.
So, considering that this entire devastating cascade, from subtle early scarring all the way to massive systemic failure, starts in absolute total silence, it leaves us with one critical question. Are you and your doctor actively checking those subtle silent lab clues today? Like that slight bump in ALT and AST? Or are you waiting for the alarm to finally ring when the structural plumbing is already broken beyond repair? Catching this early isn't just about treatment, it's about completely rewriting the story. Thanks so much for joining me on this explainer.